All right, I think we are live.
So it would appear.
Yeah, I'm just gonna have to bring up my notes really quick.
Okay. Are you recording this?
Yeah, this is automatically recorded
Wonderful.
to YouTube anyway.
Oh, right. Okay.
All right, so welcome everyone. I'm Roxana Söteber. Tonight we're talking about sleep and health. I just have to kill one background noise, just a sec. Okay, there we go. We're talking with Dr. Alan Schaffer, a board-certified sleep and obesity medicine specialist from the St. Peter's Sleep Center in Albany, New York. We'll cover sleep, how that quality matters, sleep quality, how it affects metabolic health and mood, and common sleep issues such as restless leg and sleep apnea. And we'll probably also get into some practical tips that all of you can apply tonight. Welcome, Dr. Schaffer, sorry.
Thank you, Roxanne. It's great to be here. I've been looking forward to this for a while.
So before we start, maybe you could share your own metabolic journey and explain how you decided to specialize in sleep and obesity medicine. And I think maybe we should actually start with a little disclaimer that this is not medical advice.
Right. Yeah. I'm going to read my disclaimer that I put together here. So nothing that we say here is going to establish a doctor-patient relationship. The information presented in this event is for general educational purposes only and should not be considered medical advice. Always consult with a qualified healthcare professional for any health concerns. Okay?
Yeah, that sounds fair.
All right, so let's just leave that behind us. And let me just tell you my story of, both personal and professional, how I got to where I am now, just so you have an understanding of who you're talking to. So when I was a kid, I was just thin as a rail, almost dangerously so, if you ask my parents. And then when I was 18 years old, at 6'2" and 185 pounds, I had back surgery. And after the surgery, all I did was lie around, eat, and watch TV. And within a few months, I had gone from 185 up to, say, 230 or thereabouts. And I pretty much stayed that weight for about 30 years. So that was in college when I was 18. Then I went to medical school, during which there was limited discussion of nutrition at all. Obesity was brought up. And the only thing I really remember from that time about weight management was that it was futile. Weight loss is futile. The message being not to even bother. This was the mid-1980s. Okay.
Yep.
And then I went on to do a pulmonary specialty fellowship at Albany. And while there, I did a 1-month sleep medicine elective, and I thought that was really interesting. And then I went and did a critical care fellowship at Montefiore, and then I joined my practice in 1994 in Goshen, New York, which was pulmonary and critical care. Shortly thereafter, the hospital came to us wanting to start a sleep clinic because nobody was doing sleep medicine in all of Orange County, New York. And so me having the extraordinary experience of having a 1-month elective, I volunteered to be the one. So together with the hospital, we started the first sleep center in Orange County, New York. And then I did some educational activities and became the first board certified physician in sleep medicine in Orange County, New York in 2003. And I got very busy since I was pretty much the only guy in town. And so that was 2003. And naturally, it took me until 2006 to realize that I myself had sleep apnea. I thought I was just tired because I was working so hard as a physician, but it turns out, no, I have sleep apnea. So that got taken care of, and I'm still being treated with my CPAP machine. In 2008, a series of events coalesced to where I found out about a weight reduction program with meal replacements, and I managed to lose 45 pounds back to my 185, and this took only 2 months. And I felt like $1,000,000. I felt like I was reborn. The energy, the mental, the physical energy. I actually started playing volleyball at the age of 48 years old, with kids half my age. And I was doing pretty well too. So then I became the first board certified obesity medicine specialist in 2011 in Orange County. So I was still doing pulmonary critical care, obesity medicine, sleep medicine, and so I was pretty busy. Over time, I got much more interested in the sleep and the obesity medicine because first of all, I suffered from both of those disorders, and I also felt that these are areas that are more what I call root cause medicine. In other words, related to our overall health, and if disrupted, can lead to so much of the disease that we see, rather than the pulmonary and critical care, where those are important specialties, and I found them interesting, but I felt like those were more downstream results of having poor overall health. For example, weight, diet, and sleep habits, okay? So fast forward, COVID happened in 2020, and I got involved with that, of course, as a pulmonologist. And 2023, I had the opportunity to leave my practice because I didn't want to do pulmonary and critical care anymore. And I was invited to the sleep center in Albany, which is the same center where I had done that elective 30 years ago. And I've been there since 2023 and practicing only obesity medicine / metabolic health. It really should be metabolic health / obesity medicine, but that's another conversation, and sleep medicine. And of course, those two are so inextricably linked, because so many people with sleep disorders have sleep apnea, and so many of them are overweight or have a weight problem. So it's kind of a natural. I mean, I don't think I could have designed a practice any better if I tried, but it's not how it happened. That's sort of the journey I was brought to. So I've been doing this, and I'm just enjoying it so much, really, helping people with their sleep, with their metabolic health, with their weight, and just, I have such gratitude for the ability I have to really make a difference in folks' lives. So that's where I'm at.
Yeah, that's you are making a difference. I think that's important, and that's also kind of like a calling. It's
Absolutely.
much more satisfying to help people than just do prescriptions.
No doubt. And it's even better to discontinue medications than to prescribe them, right?
Deprescribe. Yeah,
right.
Exactly.
Yeah. So since this group is reversing insulin resistance, I want to focus on insulin resistance and just say a couple of brief things as they relate to sleep. Certainly sleep deprivation, sleep disorders are very much related to insulin resistance. They're very much related to obesity. And in fact, if you do a Venn diagram of sleep deprivation, sleep disorders, obesity, insulin resistance, there'll be a huge overlap of really all of those things right in the center of the diagram. So with my patients, and we can discuss tonight, I focus on all of these aspects to try to improve people's health. Okay.
Awesome. Okay, so we have quite a few viewers. A lot of them are saying hi, like Glenn Allen.
Glenn's my patient. I saw it today. I invited him. That's awesome.
Choosing to Live says hi from Cincinnati, Ohio. There are viewers from California, Ohio, Texas, and Glenn. Actually, I would think so. I have a lot of questions. We're still trying to keep this to 1 hour because then everyone's attention span kind of wanes.
Right. And I do tend to talk a lot. So.
That's going to be good. So I'm trying to get the first question onto the screen there. Glenn Allen says, at 63 and well-treated and monitored for apnea, why does there seem to be such a weak correlation between perceived quality of sleep and perceived wakefulness and energy?
Okay. I assume you mean that in the context of having sleep apnea.
Yeah.
The thing is, a lot of people with sleep apnea will sleep a good amount of time at night. And with sleep apnea, you don't know that it's happening necessarily. And as such, you think you're getting a good night's sleep, but you wake up feeling tired and you feel sleepy during the day. Okay. So, what I'd like to do is just sort of explain sleep apnea, what it is, and how that would relate to certainly answering your question, Glenn. And I know, Glenn, you probably remember this speech because I give it to all my patients with sleep apnea. So when we sleep, among other things, muscles throughout our body relax. Muscle tone goes down. It makes sense. We're resting, right? But that includes muscles in our throat, our upper airway. So our throat muscles relax. Therefore, our throat can become floppy. So when we breathe in during sleep, the throat has a tendency to narrow or even collapse. When the throat narrows to a certain point, as we breathe in during sleep, the throat starts to vibrate, and that's what snoring is. Okay? The next step is for the throat to collapse altogether. You can't get any airflow at all, and that's called apnea, absence of breathing.
You stop breathing for a little while.
That's correct. And this is an overly simplistic, oversimplification, but this is the basics of it. So when your airway is closed, you're trying to breathe, you can't, you're still asleep, mind you. Your oxygen starts to go down, your carbon dioxide builds up, and this causes you to wake up so you can breathe. Usually, however, you only wake up for a few seconds, you go right back to sleep, and you don't even remember it in the morning. But it can happen over and over during the course of the night, so you may wake up feeling tired, and this can lead to sleepiness during the day. Remember, this doesn't happen just one night. This is every single night. So snoring, often witnessed episodes of apnea by a bed partner, non-restorative sleep. In other words, I slept 9 hours and I'm still tired. Daytime sleepiness, which can be very
Headaches
serious
too?
in terms. Yep, morning headaches can happen as the carbon dioxide builds up. That's what causes that. And so in addition to the quality of life issues we are talking about, it can also impact your health. It's been well established that obstructive sleep apnea, untreated, is associated with an increased risk for high blood pressure, hypertension, diabetes, including the entire spectrum of impaired fasting insulin through diabetes. So insulin resistance is increased with sleep apnea. Certain forms of heart disease, in particular atrial fibrillation, which is a rapid irregular heartbeat, has been very strongly correlated, and we understand the mechanism and the causation with AFib and sleep apnea, and other forms of heart disease, including coronary artery disease, blockages in your coronary arteries, and even arrhythmias and sudden cardiac death. Also, for severe sleep apnea, stroke has been seen to correlate.
So how do you know you have sleep apnea when you don't have someone sleeping with you and telling you, hey, you
Yeah.
stop breathing during the night, you should get that checked out?
Right. So a lot of times, some people wake themselves up snoring. Some people are aware of it. The non-restorative sleep, if, like I said, you're sleeping 7-8 hours and you're still tired during the day, that's a clue. Those are
How
sort
about
of the
like watches?
Very great question. The wearables, they're called, right?
Yeah,
And
exactly.
there actually are a few that are FDA approved to even screen for sleep apnea, the
Oh,
more modern ones. Yeah. I can't tell you which ones those are, but
I hope
certainly
the
a
Apple
lot of
Watch.
them have the ability to measure oxygenation, and that's often a good clue. I often get patients, who don't have a bed partner, who maybe don't feel necessarily that tired, but maybe they have high blood pressure or heart disease and they're worried about it, and they come to me with a chief complaint of my watch told me my oxygen's low. So that's certainly a good thing to do, which may also trigger, looking to see if you have sleep apnea or anything else. Yeah?
So when you have sleep apnea, the oxygen drops. Does the heart rate drop too?
It can. Sometimes heart rate goes up. Sometimes the heart rate slows down. We can even see the heart pause for a number of seconds. We call them sinus pauses. Okay. Normally, our heart slows down in sleep, whereas it doesn't typically go below 60 while we're awake, but in sleep, it's commonly down to 50 and even lower. But with bad sleep apnea, sometimes the heart will pause, and we'll see this for even 4, 5, 6 seconds. So often, I'll have a patient referred by a cardiologist who did an overnight heart monitor and found sinus pauses in the wee hours of the morning. An indirect indication that somebody might have sleep apnea.
That is actually scary. Mine goes down to about 50,
That's
unless
normal.
I'm hypothyroid. Like if I don't take enough thyroid medication, then it goes actually down
Absolutely.
to 40.
Yep.
But I've never recorded any stopping. I think the Apple Watch doesn't qualify for sleep apnea, but it will
No.
tell you how many sleep disturbances you had, and that
Right.
should give you a clue too.
Right. And, that part of it is not necessarily FDA approved, but again, it's, an
A clue to
indirect.
watch out for.
Yeah, exactly. And, like, it's usually the low oxygen that I'll see, but often patients will come in and give me data from their watches, et cetera.
So I have another question here. I'm
Certainly.
just going to bring it up. Eleni says, I'm 43 carnivore for 10 months. Lately, I've been waking up to use the bathroom around 3 a.m. and can't fall back asleep. I'm also hot. If the temp isn't 66 or less, not sure what's going on. And we talked about that actually. In Boca, we had like a long conversation about sleep, and this is what brought on the idea to do the live. And you said that if you wake up once or twice a night, that's fine. But if you
Yeah.
wake up more, it's called urine something.
So sleep fragmentation, getting up to use the bathroom to urinate once a night is not considered abnormal. 2 or more times
Okay.
might be an indication. The term for that is nocturia, nocturia. Okay, and that when we have obstructive sleep apnea, there's a hormonal mechanism via which we actually generate more urine. So it could certainly be to drinking too much water at night, but it could also be sleep apnea, and that might be a clue. In terms of the temperature, so
And
you
not
have
being able to fall
basically,
back asleep.
yeah, and that can be due to any number of things. Insomnia is very common sleep disorder, even more than sleep apnea. And there are different kinds of insomnia, and different things can cause it. If you're, let's see, so you really have a heat intolerance. So that's probably worth doing some blood work, maybe look for an overactive thyroid, which makes you have heat intolerance, can also lead to insomnia and certainly other things. So that's just one thing that comes to mind. So maybe check out with your healthcare provider on that. And I think it's awesome that you've been on carnivore for 10 months. I hope you're doing well with it. But those are some things that just sort of jump out to me.
Awesome. So we have the next question. It's, do very vivid, nonsensical dreams occur only during REM? How do they impact sleep quality?
Were you in my office today? Because I got that exact question today. So dreaming typically occurs during REM sleep, rapid eye movement sleep. And what's going on is that the brain, from my understanding, there are all different theories and it's not fully well understood. But I would actually recommend the work of Matthew Walker, who wrote an interesting book called Why We Sleep, and a lot of useful information on it. But basically, in REM sleep or rapid eye movement sleep, what's going on is that the brain is very active and the body is very inactive, almost to the point of being paralyzed, with the exception of your diaphragm, thankfully. Okay.
Yeah.
But so that's what our brain is doing is trying to sort of process our thoughts, is how I look at it. And it does so in a very fragmented sort of way. So something would have happened yesterday and in the morning, and you might get a fragment of that in your dream. And something else might have occurred, and you get a fragment of that. And so us being, logical human beings, we try to put it together and have it make sense. But it doesn't. So having vivid, nonsensical dreams is normal, and it typically occurs in REM. I don't know that this kind of dreaming occurs in non-REM, and I'm not really familiar with the dreaming characteristics of non-REM sleep. But generally, that's what it is. And these dreams tend to be more intense and occur more often as the night goes on, because that's when we have more REM sleep. It's also when our REM sleep has higher REM density, which means that a lot more eye movements happen during those REM period, and that's when the dreaming is going to happen. I hope that answers your question. Oh, how do they impact sleep quality? They don't. They're normal.
I feel like when I dream a lot, and it's actually, it feels like it's taking energy. When I wake up with it like from a dream and then straight awake, it just feels so exhausting. Some dreams are exhausting, not all of them.
Mm-hmm. Okay. I can understand that. If your REM sleep is normal, where your muscle tone goes all the way down, and it's not going to be physically exhausting. Might it be mentally exhausting? Yeah. Is that what you're talking about, Roxanne?
Yeah, I don't know. It's just, it feels like in the dream, obviously, I'm trying to say run away or run or do something, and I can't because I'm dreaming. And I'm so much trying, and that it just feels exhausting. I'm not sure whether that actually results into being probably not.
Yeah, no, I wouldn't expect that. Actually, I love waking up from dreams, because one of the things I learned from Dr. Walker's book actually was that if we wake up from REM, that is the time when we are at our most creative. So if I wake up in the morning and it's out of a dream, I'm all excited, and I'm going to grab my phone and start writing.
Oh, yeah.
and I do some of my best writing during those times.
Awesome. So I'm going to bring up the next question, and then I'm going to ask a few questions of my own. After a sleep study, no apnea, doctor suggested perhaps I have short sleeper syndrome. I average 5 hours nightly for the past 15 years. Could you address this? SSS. Oh,
I guess that
BMI 22 postmenopausal.
Right.
Oh, okay.
Got it. So the how can I put it? People sleep between 6 and 10 hours for the most part, and that's going to comprise about 95% of people. There are some people that need more sleep, some people that need less sleep. And my question, if I were to see you as a patient, I would do reasonably thorough history, ask about what your life is like, how much sleep you're getting, what your relationships are like, what are you using alcohol, are you using caffeine, do you smoke, and look how those things might impact your sleep time. There are some things like caffeine and other stimulants can mask the effect of inadequate sleep time. So those are the things I would look at, and you might want to talk to a sleep specialist. It wasn't clear if that was who you were talking to, and if so, I'm sure they would have gone into all those potential confounding factors with you. But yeah, there are a good number of people that do just fine on 5 hours of sleep.
And isn't there like a genetic difference that some people actually do not need that much sleep?
Yeah, that's what I'm talking about, right?
Oh, okay, but that's rare.
Yeah.
Okay.
I tell people, some people are wired to need more or less sleep. Yeah.
Okay, so in the beginning, we talked a little bit about metabolic health and sleep.
Mm-hmm.
After we talked in Boca, I actually dove into that subject a little.
You did.
I read about sleep cycles and that we have to have like 4 or 5 sleep cycles from with light sleep, REM sleep, deep sleep. It has to be restorative. And I also read about this midpoint of sleep. Like when you go to bed at 10 p.m. and wake up at 6, the midpoint is 2, and that shouldn't be off for more than 2 hours. I don't remember if you actually told me that or if I read that for the blog.
Yeah,
But
I probably read it.
when you mess this up, or first, probably the first question is that actually a thing? And when you mess up sleep, like to bed really late one night and 2 nights in a row, how do you recover from that?
Okay. So what you're talking about is circadian rhythms and circadian misalignment. Okay. Circadian rhythm is basically, there are many biological functions within our body that vary during the course of the 24-hour day. The most obvious one is our sleep-wake schedule, because we're going to be more alert during the day and not alert at all in the middle of the night. And boy, there's a lot to this question. I'm going to try and keep it simple, but a real important component of metabolic health is sleep health, and an important component of sleep health is sleeping at the right times. Okay, so if one night you sleep from 10 to 6, next night you stay up until 2 and you wake up at noon, and then you do that on Saturday night too, and then you have to go back to work or back to school, and you go to bed at 8 and you wake up at 4, that's going to create a circadian misalignment, okay? Because the genes and the tissues have a certain expectation and have their own circadian rhythms. And when they're experiencing a lot of metabolic activity because you're awake and doing something at 3 in the morning, it's going to create that circadian misalignment, which is a stress, and it can induce oxidative stress, right? Which is one of the precursors to inflammation, et cetera, which is why insulin resistance is a problem. They're all related. And yes, circadian misalignment is associated with developing insulin resistance, with developing diabetes, with developing obesity, with developing cardiovascular disease. So it's a real important component. So having a consistent sleep schedule is how I would redefine what you were saying, if that
Yes.
makes sense. Okay. The other thing, since we're on the subject of circadian rhythms, is eating at regular intervals and consistent eating schedules from day to day. Because again, that will, if we tell our bodies one thing one day by eating at certain times, and we tell it another something else by eating at other times, the body's going to be like, what are you doing? And we're going to have that circadian misalignment and the same issues with the insulin resistance, diabetes, obesity, heart disease, etc. So it's a real issue. It's funny. When I got home this evening from work, I found I was scrolling through my Facebook. I admit it. Sorry. And wouldn't you know it, there was a review article on sleep and on circadian rhythms and meal timing. And I read about half of it. It was very interesting. So it's an important component. Again, these are all pillars of health: good sleep, good diet, and eating at the same time from day to day. Sleeping schedule, keeping that consistent.
I mean, young parents know that if you want to get your baby to sleep through the night, you put them on a schedule. It doesn't sound intuitive, but it works. And I'm guessing
Yes.
it works for adults too.
Yeah, absolutely. But it's been a while since I was a parent to small children, but I remember it being a lot easier to say than to do. Um, and what was your question? Is the same true for children as for adults?
No, it's the same true for adults than for children, because children thrive on a schedule.
Oh yeah, absolutely, absolutely. Yeah, and
I
that's what we
actually
were
never
talking about.
thought about the
Yeah,
meal times being part of that too. That's
yeah,
like a
absolutely.
surprising new
Yeah,
fact for me.
yep. There
All
you
right.
go.
You have the next question here by Albany. I'm trying to bring it up. I do have Hashimoto's, but my T3 was low, and I've been on an increased dose of NP thyroid, now 60 milligrams. Wondering if I'm healing through diet, and maybe the dose is now too high.
Okay, so for that situation, I would certainly, of course, check with your healthcare provider. But in patients that I have with hypothyroidism or an underfunctioning thyroid, sometimes with Hashimoto's, I do regular blood work, but I also see how the patient is doing in terms of their symptoms. And wondering if I'm healing through diet. So maybe you're healing through diet. I assume you mean you've been improving your insulin resistance through carbohydrate restriction, I'm guessing. If that's the case, it would probably be worth getting some blood work to see what your thyroid status is, and of course to go by how you're feeling physically. So that's what I would recommend.
I had that problem too, that my T3 was dipping way too low, and it's probably a conversion problem too.
Yep.
I know that
So
like broccoli, I think impedes one of the pathways.
yeah.
Right?
So yeah, that's one thing. The main issue, as I see it a lot, is people who are overweight have a conversion of T4 to T3 problem, and they'll have a low free T3 and a high reverse T3. So a lot of times I'll supplement them depending on what their numbers look like, etc. And there are also some medications that can block the conversion of T4 to T3, like some beta blockers, in particular propranolol. And the worst culprit is a medicine called amiodarone, which is used for atrial fibrillation, ironically enough. But that basically shuts down the conversion. And whenever I have somebody on amiodarone, I just shake my head and say, "Oh boy, here we go." So
I'm going to throw one of my own questions in here, because I am on 120 milligrams of Urfa, which is the Canadian version of desiccated thyroids.
okay.
And I have a hard time falling asleep at night. Now, I'm taking 2 doses, one in the morning, one right before bed. And when I don't fall asleep fast, could that be keeping me up?
Yeah, it may well be. I don't know what the suggestion is of that particular preparation, but generally when I prescribe thyroid supplements, it's always to take it first thing in the morning, and once a day dosing. So you may want to talk to your healthcare provider about that.
Oh, yeah, he said I should be on twice a day because
I
the
see.
T3 kind of wanes off quickly. But when I take it right before, that just occurred to me the other day. So today is the first day I took it before supper instead of after.
Yeah. Yeah.
All right. Next question is by Jody. Hi, my husband is 55 years, 195 pounds, carnivore 5 months, no sleep apnea or snoring, and falls asleep fast. Our Aura Ring, so that's one of the wearables.
Sleep trackers. Yep.
Yeah. Says 0 to 10 minutes deep sleep, room temp 68. What is the best way to get more deep sleep?
Okay. First, I would want to know how tall he is with that 195 pounds. Second of all, I would want to know how, when you say no sleep apnea, does that mean he was tested or he has no symptoms of sleep apnea? Because those things can be very different. Sometimes asymptomatic patients can have sleep apnea, but I think that's less about what the question is. The Oura Ring saying 0 to 10 minutes of deep sleep. So at 59, as we get older, we tend to get more deep sleep. Deep sleep is the stages of sleep. There's wake, stage 1, which is transitional sleep, where we're falling asleep or waking up from sleep, and it's about 5% of your night. Stage 2, which is your garden variety sleep, which is about 50% of your sleep. And then there's deep sleep and there's REM sleep. And those are very distinctly different stages. Deep sleep, you're very quiet, very hard to wake up often. There's your heart rate and your respiratory rate will be very regular. And the other thing that happens with during Deep sleep, also known as slow wave sleep, because the EEG waves are high in amplitude but slow in frequency, is that's when we produce growth hormone. So children, adolescents have a lot of deep sleep because they're growing and they need a lot of growth hormone. As we get older, there's less deep sleep. Okay. The other thing is that as we get older, don't want to get too much in the weeds, but the amplitude, the height of those slow waves, because usually they're very tall waves. And so as we get older, they get shorter. And as a result, they wouldn't meet criteria for slow waves or deep sleep. So that's another reason that deep sleep, as we measure it, might go down as we get older. I can't say just using the Oura ring what the significance is. I would want to know more about his health, obviously. But to answer your question about getting more deep sleep, exercising, building up a lot of adenosine, ATP is a good way of getting a lot of sleep. Sleep deprivation, although I don't recommend it, is going to push you more into deep sleep rebound. So you're going to have more deep sleep if you don't sleep the night before. Again, I don't recommend that. Taking a hot bath about 2 hours before bedtime has been shown to increase deep sleep.
Interesting.
And relaxation techniques may also be of use. So those would be the things I would recommend. And of course, those have other health benefits as well.
That brings up another thing that I just learned about. Something beats. It's different sound waves on both ears.
Oh, yeah.
And I forgot what it was named. Something beats. What do you think about that for sleeping?
Asynchronous beats, maybe.
Yeah, it was something else.
Yeah, but I'm not. I've heard it. I've read a little bit when I've seen advertisement for those sorts of things, and I suspect they're helpful. I'm going to have to plead ignorance on that because that's not something I really looked into in great depth. But I'm thinking that's certainly not going to be harmful. And if somebody does find that helpful, then by all means.
I tried it a few nights, and it's turned out that I had to sleep on my back because I couldn't lie on my earphones, and so I slept worse. The great, but it was just bad.
Sure.
Okay, I'm going to bring up the next question here.
I'm going to do one more question, and then I'm going to want to intervene with another pearl. Okay?
Yes, that sounds good. No, we already had that. Let's do what you have to say first.
Okay. So I talked about sleep apnea, what it is and what it can do, but I didn't talk about treatment. The best treatment for sleep apnea, and that's what I often focus on with my patients, is to reduce body weight because it's a mechanical thing. When we have extra fatty tissue in the abdomen, in our liver, fatty liver, right, all part of the insulin resistance thing, in our pancreas, we also have excess fatty tissue in our upper airway, particularly in the back of the tongue, the sides of the throat that narrow the upper airway. And sleep apnea happens whenever anything that can narrow the upper airway. Most commonly, it's excess weight, but it doesn't have to be. I have still severe sleep apnea when I'm on my back. Why? Because my upper airway anatomy. I'll show you. Let's see if this works. Can you see my
Yep.
chin, how it's all the way back here? So the chin is the tip of the mandible, the lower jaw, and it's attached to the tongue. So when people like myself have a recessed chin, the tongue tends to be closer to the back of the throat, thereby narrowing the upper airway. So that's another thing that somebody maybe who isn't overweight might have sleep apnea. The other treatment we use is the CPAP, okay, the mask. You familiar with that, Roxanne? I know a lot of people are.
Actually, I had like morning headaches, and then the doctor had me do a sleep study at home. and that
Yeah.
was evaluated, and they said, well, you might benefit from a CPAP machine.
Great.
So I said, okay, I'm going to try it. I couldn't tolerate it, so I'm not on it
Okay.
anymore. I know that's like not
Okay.
very smart. Maybe I should
No,
have
well,
another sleep study
let
done.
me frame this instead of individually for you, just sort of in general,
In general, yes.
because what you brought up are an important point. I'm going to talk about sleep studies and the various types that we do also. So the therapy for obstructive sleep apnea is to wear CPAP. So CPAP is CPAP. It stands for continuous positive airway pressure. You wear a mask over the nose, sometimes over the nose and mouth, with an airtight seal, and it's connected to a little bedside unit that generates pressure and blows air in through the nose. It's not oxygen, just compressed air. It's a very simple concept and it works very well. So maybe some of your viewers watch television and they see these advertisements for alternate treatments of sleep apnea. And of course, they're going to make the CPAP look like it's an absolute nightmare, right? Pun intended. But I want to show you the mask that I use. And it's from my experience, personally and professionally, it's really the least intrusive of all the masks. So I'm going to put this on and take my headphones off. So don't talk to me.
Okay.
So it's held on by just one Velcro strap, put in the back, and then put it back here. And this just sits under the nose like that. And put it right like that. Okay, and the tube comes out of the machine and attaches to this little piece up here, which is nice because a lot of the CPAP masks, the tubing is right in your face. Here it's out of the way, it swivels, and so I just put this behind me and out of my way. The nice thing about this also is you see the opening. This is, let's see, where the air comes in through. So it gets transmitted from here down here and just goes inside the nose. There's nothing that goes and it goes into the nose. There's nothing that goes inside the nose. A lot of sleep apnea masks will have nasal pills that go inside the nostrils. I personally find those to be irritating and they can kink and get lost. There's also nothing on top of the nose. A lot of the masks that are used will be more like triangles like this, sometimes over the nose and mouth, sometimes over just the nose. And there can be a pressure sore over here on the bridge of the nose. And that's very uncomfortable for patients often. So again, my experience, this is the most comfortable CPAP mask. And I look at it as like, it kind of looks like I'm wearing oxygen, but maybe a little more bulky, but not too much. I can sit, I can read, I can talk to my wife, I can talk to you. I think it looks good too. Maybe I'll keep it on for a little bit. So I just wanted to share that with y'all. Okay.
I don't remember quite how my mask was. It was over the nose. I'm pretty sure about that. And
right.
I did feel that pressure.
Yeah. So, with my patients, sometimes when I talk to them about getting the CPAP, I prescribe it for them. And the newer machines, it used to be you have to do another sleep study to determine how much pressure you use, but now the machines are smart and you can just put a range that the machine can actually read your breathing pattern and go up and down as needed. So when I prescribe CPAP for my patients, I always tell them all that. I show them this mask. I have one in my office. And I tell them that, see how you do with it. Some people take to it like a fish to water. Some people have a hard time tolerating it. For some people, the mask isn't quite the right one. It doesn't fit. It doesn't feel good. It's leaking here and there and everywhere. The pressure is too much. The pressure is too little. So it's not, it's not like I give you a medication and say, come back in 6 months. This is a process, especially early on. I want this therapy to work for my patients. So it's important to tell them that this isn't the end, but this is the beginning of putting together the best treatment for you. And I encourage patients, if they have any of these issues, to call. And in fact, I insist that they do. And I tell them that I'm often mad at patients for not calling, but I've never been mad at a patient for calling. Okay? So there it is.
So basically, if someone is diagnosed with sleep apnea, It is not like when someone is diagnosed with type 2 diabetes and they throw medications at that patient. Sleep apnea needs to be treated. It's not optional,
Yeah.
right?
It it really depends. So definitions. So obstructive sleep apnea syndrome is a condition where you have certain symptoms and then you have certain findings on a sleep study. Sleep studies will indicate what's called sleep disordered breathing. So in other words, you're stopping breathing or slowing down. Your oxygen may go down. You may be waking up a lot at night. And when somebody has mild sleep disordered breathing, which is defined by typically between 5 and 14 episodes per hour, the decision to treat somebody like that is going to be based on symptoms, which can be snoring, daytime sleepiness, witnessed apneas, hypertension that's maybe hard to treat, atrial fibrillation, that sort of thing. But it's even questionable and judgmental. So, and there's a lot of judgment involved in that. So you don't necessarily need to be treated for mild sleep apnea. Again, for me, it's a case-by-case basis. Anybody with moderate sleep disorder breathing or more, it's recommended that they be treated. So I hope that answers your question on it.
Yes.
And I want to talk about home sleep studies because it's another important corollary to all this.
Yeah,
go ahead.
I'm thinking that my sleep apnea was probably mild, and I did stop snoring since I lost the weight. I remember when before I lost 100 pounds, before that weight loss, it was difficult actually on the pillow to find a spot where my throat wasn't impacted in a way that I couldn't even fall asleep because I couldn't get air, and it was that was one of the worst things of being that overweight.
So what made me think of that is I've seen a picture of an experimental mouse that was made obese and had sleep apnea, and they would sleep standing on their hind legs against the wall, and their head would be like this.
Oh no!
So they could breathe. Can you imagine?
No.
So
tell me more about sleep studies.
Okay, so originally we were doing sleep studies in the sleep center. You would come in, you would spend the night. They would hook you up to a whole bunch of monitors, EEG leads, so we can measure sleep, brain waves, you're awake or asleep, what stage you're in, a sensor between the nose and mouth looking for airflow or absence thereof in cases of sleep apnea, a bunch of other things, EKG leads, oximeter on the finger or on the ear, whatever. And so we would look for that. Now, we would look for sleep apnea as well as other conditions as well, other sleep disorders. They've come out with, in the last 10, 15 years, portable monitor sleep studies, which are basically designed for one thing and one thing only, and that's to look for evidence of sleep disorder breathing, sleep apnea. Okay? Now, those home sleep studies will measure airflow, will measure oximetry, oxygenation, and will measure respiratory effort. There's a band around the chest and around the abdomen, measuring stretch, looking for effort. Okay. So those studies are very helpful if they show clear-cut sleep apnea. However, since we're not even measuring sleep, if a home sleep study tells me somebody has mild sleep apnea or doesn't have sleep apnea at all, I cannot take that to the bank at all. Okay. So home studies are effective in ruling in sleep apnea, but notoriously inaccurate
in
for
ruling
out sleep apnea. So when you tell me you had mild sleep apnea based on a home study, that's very nice. Perhaps you do. But
I better get it rechecked and maybe go into sleep center.
But the best thing, Roxanne, is that you lost the weight and your symptoms got better. So your sleep apnea, which was mild when you weighed more, I presume, yeah?
I was in the category of super obese. Can you imagine that?
Right. But you weighed more than you were. Yeah, I know. The terminology.
Yeah, about 120 pounds more. Yeah.
Yeah, terminology basically developed in order to fat shame people. What could possibly go wrong?
Yeah, I think it was obesity stage 1, 2, and 3.
Right.
And then now they have 4, which they call it.
Yeah, there are different ways of looking at it. So, so if you had lost quite a bit of weight and are no longer having symptoms, I'd be much more confident that you, in fact, have mild sleep apnea, if you even have it at all. So it might be worth looking into if you have concerns. But again, talk to your healthcare provider.
Yeah, absolutely. And just a reminder, all this is not medical advice.
Absolutely.
No longer morning headaches. I do wake up exhausted, but that's from lack of sleep, not from not being able to
Yeah.
breathe.
That's
So,
what I thought in 2006 when I was diagnosed with sleep apnea.
oh yeah, you're right. Well,
You just never know.
the thing is, I know all the good advice, but applying it is a totally different thing. And so I need to dial in my circadian rhythm and regularity and the amount of hours. 5 or 6 hours doesn't cut it for me, that I know.
Right. And for most people, it doesn't.
Yes.
Myself included.
People
Yeah.
think they can get by, but most people can't. And that's another
Right.
thing. This genetic thing is rare. Okay, so
It
I'm
is
going to
rare,
bring
yeah.
up the next question.
Sure.
This is by Eric. Carnivore 3 years, 64 years old. I fall asleep in minutes, usually wake up after 4 hours, go back to sleep, and sometimes wake up 1 to 5 times before 8 hours in bed. I don't feel tired during the day.
Awesome. I'm guessing you feel rested when you get up after 4 hours and then when you get up after your 8 hours in bed. My question would be, how much time do you feel you're actually asleep versus time in bed? When you wake up 1 to 5 times per night later in the evening, how long are those awakenings? So those are things to consider. The fact that you're functioning well, the fact that you're on a carnivore diet for 3 years. And I, again, want to know your other metabolic issues, of course, before advising you. But so it sounds like it's those frequent awakenings later at night. And I can't really, could be any number of things. Are you drinking a lot of water at night? It could be you just don't need that much sleep. It could be, what else?
Noisy environment.
Are you going into more REM sleep as we typically do later at night? Maybe you're having a little apnea that's causing you to wake up, or maybe you're not. It's hard to say.
All right, before I bring up Vicky's question, my son just started as a paramedic and he has a lot of night shifts. And I know that's horrible for him. So
Yeah.
her question is, are shift workers likely to suffer from circadian misalignment?
Yeah, absolutely. I mean, by definition.
I would say so too. Luckily,
Yeah.
he doesn't have to be up all night, but
Yeah. So, that's one of the main causes of circadian misalignment, and it's a real health issue. And there are different things you can do to try to improve things. As a night shift worker, I don't have a list of things here, but it's just sort of, again, keeping a regular schedule sleep schedule when you're working and when you're not working. But again, life doesn't always let you be awake all night and then sleep during the day when you're not working. Try to manage that also. Again, regulating the times that you're eating during the day, at night, overnight. Physiologically, during sleep time, it's not great to eat. Maybe if you're in the middle of a busy shift, have a little snack, a little small something to get you through, that sort of thing.
not a big meal.
Light, yeah, for sure. Adjusting light exposure to better align with your circadian schedule. But that's often a very difficult problem.
Is there a protocol where you say, okay, I'm the few things you mentioned, like the light exposure and the meals, not having heavy meals, but is there a protocol how you best recuperate from night shifts?
So it really depends what your schedule is. So if you're doing four nights off, 3 nights on, then after your 4th night on, I said it the wrong way. But anyway, after a string of night shifts, get some sleep during the day, and then make sure you're busy, maybe 3 hours or so, wake up at noon, keep yourself busy until it's time to go to bed at night, and then start with a more normal circadian schedule that way. And then when it's time to go to work that night, when you wake up in the morning. Um, go about your day, but um, think about taking a nap in the afternoon or before work or some such thing. And there are various, things. If you look under aasmnet.org, that's the American Academy of Sleep Medicine. They probably have some information on that, and really on many aspects of sleep health. They'll be very helpful. aasmnet.org.
Okay. Is there something to this that first thing you wake up in the morning to get your circadian rhythm better aligned, to not look into the sun but have sunlight shine at you?
Yeah. So again, melatonin is the hormone that regulates our sleep-wake circadian rhythm, and light exposure suppresses our melatonin. So a normal circadian rhythm would be, say, 7 o'clock in the morning. Level's pretty much zero, and it gradually increases during the day. I'm sorry, it stays low. Excuse me. It stays low during the day. After lunch, like maybe 1, 2 o'clock, 3 o'clock, there's a little bit of a blip, an increase that's not long lasting, the siesta effect. So siesta is physiologic. It's not just cultural in some cultures. And actually, there's some data that show people who do nap in the middle of the day live longer. So
Oh, good.
then, okay. So then around 6 p.m. or so, your melatonin level starts to rise again gradually, and it'll peak around 11 p.m. You go to sleep, it stays up all night, and then it plummets again at 7, and you wake up naturally. So what exposing yourself to light first thing in the morning does is it suppresses any residual melatonin and may help entrain your circadian rhythm one way or another.
And that's 7 to 11 or 11 to 7. That's kind of like a number that our bodies expect.
Yeah.
Or can you cannot just say, okay, I'm going to go from 2 a.m. to 10 a.m. every day. That doesn't work, right? You can't cheat
You
yourself away
you
from the sun.
if you do it every day, you can do that if that's what you want to do. And there are some people that are just night owls and they will do that. But then there is the circadian rhythm misalignment with the external light, with
Yeah.
any social cues like having to go to work or kids to school, whatever it is. And there are ways that we can entrain circadian rhythms. There are a lot of people that have certain circadian rhythm disorders. The common ones are delayed or advanced circadian rhythm. So, for example, delayed circadian rhythm is when instead of getting tired at 11, you get tired at 1 or 2. And
Okay.
you can't fall asleep until 1, 2 in the morning. And you can't wake up for school or for work. And so a lot of times people will get in trouble in school or at work and then 10 o'clock and they're fine the rest of the time. So what that's actually, I see we're running out of time, but that's correlated with depression. And it often starts in post-puberty teenagers, because when we hit puberty, for some reason, there's like a 1 or 2 hour delay in our circadian rhythm. That's why one of the reasons teenagers stay up late. There's also, of course, the social thing of wanting to be with their friends, all the screen time, which suppresses the melatonin, which even has them stay up later. So it's very common to start in teenagers. Usually, as we go into adulthood and the social pressures of having to go to college or to work or whatever, or get the kids up, it gets re-entrained. But if it doesn't, that's delayed sleep phase disorder. And we have ways of recommending patients adjust their light exposure times and their light avoidance times. We also will give a supplement of melatonin to help entrain the circadian rhythm as well. And I don't want to go through the whole details and everything.
You take that
But
melatonin like how long before sleep?
well, that's the answer. So people think melatonin is a sleep aid. And while it will make you drowsy, that's not why we use melatonin in sleep medicine. We use it to entrain our circadian rhythm. So depending on what kind of sleep disorder you have and what your natural sleep-wake circadian rhythm is at the time that we're treating you, the timing of the melatonin supplement is critical. If you take it too late, it's not going to do anything. If you take it too early, it's not going to do anything. If you take it really too late or the wrong time, it may actually make the problem worse. So that's the kind of thing.
And that really depends on what problem you treat. It's not like a half an hour before bed for everyone.
Not even close.
Oh, okay. So Glenn said it's binaural beats. That was the word that I couldn't remember. Binaural beats. I'm going to bring one more question, if that's okay.
Of course.
Because that's close to my heart too. I often have, actually not anymore, nightmares. So the question is, do vivid dreams prevent a person from getting deep, restful sleep? I occasionally have severe nightmares.
No. I mean, if you have night terrors, you wake up frightened from nightmares, or if you have nightmares that will disrupt your sleep when you wake up from them and your heart rate is going fast and your blood pressure is up and you're anxious and nervous and worried and can't sleep, yes. I don't look at that as much as the nightmares being the problem, as much as insomnia being the problem. Okay. There are some conditions that are associated with nightmares. Psychiatric conditions, the most famous would be PTSD, post-traumatic stress disorder. Very commonly involves nightmares, recurrent nightmares, flashbacks, that kind of thing. And so in that case, yes, nightmares and the being terrified from waking up will just, can disrupt your sleep if you can't get back to sleep. But the dreams themselves, aren't what's causing the disruption, if that makes sense.
All right. So thank you, Alan, for your insights. And for those watching, please share this video with anyone who needs better sleep. Like we talked about, prioritizing sleep is essential. It's not optional.
Yeah.
I think really we should do this again because there are still open questions, but I would hate to keep you longer. So awesome. Yeah. Thank you very much.
Thank you. All the best to you, Roxanne, and everybody else. Thank you for joining us.
Thank you.